Hi, nurses. So I had a patient the other day with a tracheostomy tube, and it was to a T-tube where it looks like endotracheal, it looks like vent tubing, but it just goes across. And so it's not connected to the vent. The tube is just open on one end, and it kind of is shaped like a T. And so the oxygen kind of just blows past the trach so that as the patient is breathing, they're getting the oxygen, but they don't need the ventilator support. Okay, so they call that a blow-by or a T-tube, trach tube, those kinds of things. So I had a patient with that, and they started to desat. And so, okay, well, why is the patient desatting? We checked the equipment, and it was an accurate reading, and the patient was desatting into the 70s. Patient looked okay. They were still responding. They were still following commands, those kinds of things. They weren't turning blue yet. And so we increased the oxygen that was going through this trach tube, and it went up a little bit, but still was staying in the 80s and couldn't really get it to increase enough for the patient. And so come to find out, the trach tube was blocked or dislodged. And so, the trach tube sits right in here, and with a lot of movement, that trach tube can get dislodged and not be blowing into the lungs adequately, or it can be up against the side. The way we figured that out is that the RT, of course, I called respiratory therapy to come and help me because the patient was having distress and I was having issues with an oxygenation problem. So RT came in and they attempted to suction, thinking that maybe that's why they were desatting. And the suction tube would only go so far, and it should go all the way down into the lungs so you can suction the secretions. So that wasn't working. So we then called the intensivist to come and take a look, and he did kind of the same types of things. We tried to lavage the patient. We tried to suction again, and it wasn't working. So we did a chest x-ray, and we ended up putting a face mask on the patient because the trach was no longer functional. And so we put 100% non-rebreather on the patient, and they were doing fine. So the surgeon who put in the tracheostomy has to come in and replace the tracheostomy tube. And the intensivist's thought was they need a bigger trach size, that it wasn't a big enough trach tube for that patient, the size of that patient. And luckily the patient was oxygenating well with the mask. Now, if you have a patient with this problem, and the other thing to feel for is subq emphysema, the Rice Krispie feeling of air in the tissue around the tracheostomy, because that is another sign that the trach is dislodged and it's pushing the air outside of the lungs into the tissues. And it feels kind of like a bubble wrap or a Rice Krispie. So that those are some signs that it's dislodged. The other thing that you would do then, if the patient was not doing well with the face mask, is you would intubate the patient. So you would intubate from the top, and you would put the endotracheal tube in just above where the trach is, and hope that this system is still intact enough to get the oxygen down into the patient's lungs until you can replace the trach. So those are some things to do. Another thing is, I remember quite some time ago, when I was a fairly new nurse to the ICU, I had a patient that was desatting, and so we were going to bag the patient with an ambu bag. We attached it to the trach, and every time we would inflate the bag, the patient's tissues would kind of inflate. And it was because the tracheostomy was displaced, and the air that we were pushing into the lungs, some of it was going in the lungs and some of it was going in the tissues. And then you could feel that Rice Krispie feeling around their face. And their face kind of blew up like a balloon, and it was so inflated, the patient's eyes were kind of swollen shut, and it was all air in their face. And so we ended up having to intubate the patient because the tracheostomy was dislodged. Patient did fine. Over a few days, the air started to be reabsorbed into the body, and the patient was okay. But I just wanted to talk a little bit about troubleshooting the trach, and some signs of dislodgement, and some things that you can do when the trach is dislodged. It can be kind of a scary situation. So that's all I have to say about that. And You can also put the patient back on the ventilator if they're desatting, they have a trach, and the trach is still functional and not dislodged. That is another option. I guess I should have mentioned that too, if your patient is in distress. Okay, so I'll see you next time. Make sure you go over to my YouTube channel and subscribe and like my videos, and I will keep making content like this for you. I've got a Patreon coming, so stay tuned. Thanks.